A very good evening and welcome to this series of webinar hosted by HaystackAnalytics. I am Dr. Mahua Dasgupta Kapoor. I'm the Director Medical Affairs for HaystackAnalytics. And it is something very interesting. I have been looking forward to this session for a pretty long time. A person I revere, honor, and want to learn from is with us today with his rich clinical experience, insights, and the knowledge sharing that he was very kind to agree for. Um, just for people who are new to this, new to us, and the first time joinees, HaystackAnalytics is a homegrown company. It started in 2019, so we are really at the toddler stage. Our inception was at IIT Mumbai, and then we grew out and now have a space, our central location at Navi Mumbai. We have just one mission, that is to empower diagnostics globally, especially in the foray of infectious diseases. And when I say this, what is very valuable is if our mission matches that of an infectious disease specialist. If they really feel that the work being done by us is going to make significant impact in the patient outcomes that we all are chasing, if we can reduce the stay of a patient in the hospital, reduce the critical care stay for the patient, reduce the cost of therapy, reduce the inappropriate use of antibiotics, if we can contribute to antimicrobial stewardship practices, if we can deliver better health outcomes, if we can provide better epidemiological insights for public health policies, then I would say that we have succeeded in our mission hand in hand with the ID specialists who are at the front line battling the crisis at hand. So this has been our journey so far. I'll not elaborate on this, but as you see, we started off with one bacteria, one infection, one technology, and we expanded it to be inclusive as far as possible, to be as comprehensive as possible, to improvise and make infectious disease diagnostics very robust. What has been our core approach is, can we move to a hypothesis-free world? And it is not for me to elaborate on this. I think today we all need to hear it from the horse's mouth. A person who is at the bedside of a patient, a person who faces a clinical dilemma every day to work. Does that person feel that infectious disease diagnostics needs a revamping? Because an idea, a product is only as valuable as it is in the hands of the user. So introducing to all of you, and I take great pride in introducing the person who actually needs no introduction, but it's Dr. Abdul Ghafur, a mentor, a teacher, a person who has been at the patient bedside for a very, very long time. That adds value to every word that he speaks this evening. He's a senior consultant and an adjunct professor of infectious diseases at Apollo Hospitals, Chennai. He's a managing partner and lead strategist of Coram Veda Consulting. He has his expertise and area of focus in antimicrobial resistance and antibiotic policy, in infectious diseases, both clinical and public health, in healthcare strategy and system innovations. He's a key contributor and has been a lead author in the Chennai Declaration, has been a managing trustee in the AMR Declaration Trust, is a former advisor of the National Antibiotic Policy Government of India. Sir, I must say this is actually something we all would someday aspire to be, the role model that you have played and the contribution that you have made, not only in the life of a patient in your day-to-day journey, but overall, I think the way infectious diseases guidance is being formulated in the country and abroad. So he's been an advisory and a jury member of the Longitude Prize in UK, has several publications to his credit in some of the high impact factor journals, has been a speaker at global conferences. I have been very fortunate to see him actually moderate a debate, and I must say it was a very passionate moment that I experienced. He's been, and no wonder he's been he has been awarded the IMA Oration Awardee. So, sir, welcome you, and I'm so grateful and honored that you are amidst us for the HaystackAnalytics webinar. Right at the 4, let me declare today morning I was having a word with sir, and I was again. It was a moment of learning for me. Sir gave a fantastic idea that this needs to be a webinar series specifically. When we are talking about the revamp in infectious diagnosis, we are talking about a bouquet of infections, and it cannot probably be justified in one session. So, this is going to be a series. So, uh, I'm so happy all of you are here to attend this today, but I also request to be hooked to this webinar series as we come up with more with Sir as the speaker. We will take up each syndrome at a time and we will get great insights from real world applications. Sir, as we start, I think there are some queries that have been playing on my mind now that I'm working on the other side of the table, but would really want to hear the clinician speak on that in your rich expanse of the clinical journey which you have had. What has been the most frequent infection that you have experienced? In solving for the same, has there been situations of clinical dilemma, and what is the approach that you would usually follow in such a case? What are the legacy methods that you have been resorting to? The second is, in your opinion, given the constraints, or if you have ever felt that there are certain limitations, would you want to break free? Would you want to untie the knot or actually cut open the knot? Is a change envisaged? And lastly, why do you think the change that is being proposed is or should be the change that should be a daily deployable solution at your end for your use for your patients? So, with this, I hand over the session to you, sir, and thank you again.
Thank you, Mahua. Is my slide visible? Am I audible, Mahua?
Yes, sir. The slide is visible and audible.
Thank you, Haystacks, and thank you, Mahua. Now, I've been active in the field of AMR for at least for the last 2 decades. What I learned over my journey is, yes, we can make policy changes in Delhi, but we need to implement those policies on the ground. And to make a change in a big country like India or anywhere in the world, we need innovation. Innovation is the way forward for making a successful national AMR policy implementation. And I'm a big supporter of Indian innovation. And we are proud that HaystackAnalytics have come up with an amazing NGS platform that's can play a significant role in the AMR journey. So as a policymaker and a supporter of innovation, yes, I'm a supporter of any innovation, especially Indian innovation. On the other side, as a clinician who treat patients on the bedside, let's analyze in a very neutral perspective. What's the role of various investigations, various microbiological investigations in our day-to-day clinical practice? We can discuss about any syndrome, we can discuss rare cases or any of the infection challenges. But as clinicians, we approach patients as syndromes. And the commonest syndrome is pneumonia syndrome. And let's discuss what's the role of various investigations, microbiological investigations for the diagnosis of pneumonia syndrome. What's the problem with the pneumonia diagnosis is, just like the microbial community in the world, the 99.99% of the microbes in the world are harmless. They are neutral. Only 0.001% produce any kind of disease. And this is the same challenge that we will approach while trying to diagnose, making a microbiological diagnosis of pneumonia. The respiratory tract has millions of the microbes, and we are hunting a rare minority of pathogens in that respiratory tract. And that's the challenge we face whether we do a gram stain or a culture or a PCR or a metagenomic NGS. And we need to keep this challenge in mind. And pneumonia is still a challenge because that's the commonest syndrome. The commonest cause, infection cause, a patient gets admitted to the hospital. And it has got global consequences for the morbidity, mortality, and socio-economic perspective. And overuse of antibiotic for respiratory syndrome is the commonest cause of misuse of antibiotics in the human world. The problem of pneumonia diagnosis is not lack of test. The problem is with the interpretation of the test. That's a challenge. Not the lack of test, but the lack of the challenges in interpretation of this test. The first principle and the most important principle, the specimen is the first test. Specimen is the first challenge. Every diagnostic test depends on the specimen quality. And that is especially applicable to the respiratory tract with millions of the normal microbes, bacteria, virus, even fungi sitting in the respiratory tract. And we know the BAL has got the highest diagnostic reliability. Endotracheal aspirate, moderate. Sputum, the lowest reliability. We know the contamination reduces as we move from the upper airway to lower airway. And molecular tests amplify colonizers as well as pathogens. Again, we need to keep this in mind. Before ordering a test, choose the right specimen. The sample you send to the microbiology laboratory makes all the difference. Whether you do a gram stain or a metagenomic different by the NGS, the most important thing is, are we sending the right sample? You send the right sample, you get the right result. You send the wrong sample, you get a very bad result from the microbiology or molecular laboratory. And there are clinical consequences for these pre-analytic errors. Why good tests fail? The most diagnostic errors in pneumonia happens before the sample reaches the laboratory. It happens on our bedside. Wrong samples produce false negative cultures, false positive PCR detection, and colonizers are misinterpreted as pathogens, unnecessary escalation of antibiotics. A diagnostic test is only as reliable as the specimen sent to the laboratory. And what are the common pre-analytical problems? A sample collected after antibiotics started, wrong site sample, a poor quality sputum, delay in transport to a laboratory, improper storage temperature, and the dilution effect during bronchoalveolar lavage sample collection. The ventilator circuit contamination for an endotracheal tube aspirate. Look at this example. The specimen quality. The sputum culture grows mixed oral flora. Interpretation, likely saliva contamination. And what's the clinical message? The specimen quality determines the microbiological validity, the principle. Gram stain. Never forget about gram stain. The fastest pneumonia diagnostic tool is not PCR, not NGS, not culture. It is the gram stain, if gram stain is available on the next room near the ICU. Unfortunately, no hospital has got a gram stain next room. The advantage of gram stain, the result is available within minutes. It has got significant bedside clinical relevance and given immediate direction for empiric therapy. And it assesses the specimen adequacy and inflammation. You do a gram stain, if it's not a good sample, there is no meaning in sending the laboratory, that sample to the laboratory for culture, for multiplex PCR, for NGS. You do a gram stain, that makes hell of a difference for the quality of the report that you get from any of these samples, any of these tests. And we know that the quality depends on the presence of polymorphonuclear neutrophils and on the squamous cell. The more the squamous cell, the bad the specimen is, more PMNs, the better the specimen is. Inflammation is presence of neutrophils. And look at the morphology, gram positive, gram negative, give you a good idea which empiric antibiotic you can start. And we all know this. Less than 10 squamous cells accept the sample, 10 to 25 interpret cautiously, more than 25 squamous cells reject the specimen. Look at this. The endotracheal aspirate smear shows many neutrophils and gram-negative rods. It's likely through lower respiratory infection. So the gram stain, this gram stain picture can guide therapy immediately. Immediately. This is my favorite picture. 1984, Hans Christian Gram invented the gram stain. 1884. That was how many years ago? Almost 150 years ago. And that is my next favorite picture. I'm a big connoisseur of perfumes and fragrances. 1882 was the first synthetic perfume called Fougere Royale by Paul Parquet. 2 years before Hans Christian Gram invented gram stain. Almost the same time. Now, why culture still matters in the molecular era? The cultures give us the phenotypic susceptibility. That's very important, phenotypic susceptibility. It gives us the MIC values, detection of unexpected organisms, and epidemiological tracking. The culture makes a lot of difference. The PCR detects nucleic acid. The culture detects live organism. The PCR, but advantage, PCR may become positive, remain positive after antibiotics, after organism death, and with the colonizers. It can be an advantage or a disadvantage. The culture determines the treatment. The molecular test guide early decision. Culture determines the treatment. The molecular test guide early decision. That's the principle. Now, this scenario, the PCR detects multiple organisms. The culture grows only as an Heterobacter. What's the interpretation? The true pathogen is the organism growing in culture. The culture determines the definitive therapy. The early pneumonia diagnosis determined more by the specimen quality and not the test sophistication. Now, this semi-quantitative culture is still useful. Is it scanned? Is it moderate? It's heavy. And this microbial burden matters because a high burden organism more likely pathogen. A low burden organism most likely a colonizer. So, whatever you do, any laboratory report that you get, interpret with clinical syndrome. In pneumonia, gram stain and the specimen type and the clinical syndrome, the clinical presentation, these three plays a major role in how you interpret a clinical test. A semi-quantitative culture is not just some approximate microbiology. It's a very clinically meaningful signal. Look at this example. Now, invasive, quantitative. For example, we can do a bronchoalveolar lavage with a CFU threshold for the culture, higher specificity. We know that. Or a non-invasive test like an endotracheal aspirate will give you a faster sampling. Now, what is a randomized control trial finding? You compare with an endotracheal tube aspirate or a BAL, there is no consistent difference in mortality, no difference in ICU stay, no difference in ventilation duration. Antibiotic use outcomes inconsistent. So, there's no need of doing a BAL for all the patient pneumonia in the ICU. You choose invasive sampling selectively, not routinely. Of course, in immunocompromised patients, it is a different scenario. In people with difficult to treat pneumonia, worsening pneumonia, unexplained pneumonia, that's a different scenario. Routinely, no need of BAL for every pneumonia. Then we have the rapid viral testing, the antigen testing. You'll get the result in few hours. It guides infection control, droplet or respiratory isolation decisions, and identify treatable viruses like COVID, flu, or RSV, and reduces the unnecessary antibiotic. So it can be used as a tier 1, a triple PCR. For example, influenza, COVID, RSV. You can do it OPD, emergency department, a ward triage, and seasonal outbreak plays a big role. And if it is a positive viral test, increases the probability of viral disease, but doesn't exclude bacterial pneumonia, especially in immunocompromised patients, severe pneumonia, elderly, or ICU patients. Just because a virus is positive doesn't mean a bacteria or a fungus or a parasite is not there. Let's look at this example. A young patient, fever and cough, triple PCR positive for influenza. It's a virus infection, but rapid viral testing can prevent unnecessary antibiotics in mild cap, and viral PCR guide early decisions, not the final decision. In severe pneumonia, just because a virus is present doesn't rule out other pathogens. Now there are expanded viral panels. So many viruses with a few atypical bacterial organisms. You can use it in ICU pneumonia, immunocompromised patients, severe CAP, outbreak investigation, unexplained respiratory failure, but not routinely needed in uncomplicated mild CAP. But there are interpretation challenges. Respiratory viruses may shed for days or weeks, even after the patient recovers from the infection. And detection, so the detection may represent active infection or resolving infection and even asymptomatic carriage. So we should be careful while interpreting the result. So this patient, stable patient, focal consolidation, respiratory viral panel, rhinovirus, interpretation, likely incidental detection. Detection doesn't equal causation. So this viral panel may detect a virus, but that may not be always the one that is causing the disease. Don't miss another important pathogen like a bacteria or a virus or a PCP or a fungus. Syndromic pneumonia panels, they detect bacteria, virus, atypicals, a lot of resistant genes, and will give you a semi-quantitative load. The advantage results in few hours, 1 to 4 hours, you can get this multiplex pneumonia panel reports. It will help you in early targeted therapy, early de-escalation. What they cannot replace, these PCRs do not provide full susceptibility or MIC. The syndromic panels accelerate diagnosis. They don't replace clinical reasoning. We need culture. Culture is still required. Look at the example. Yes, the ICU patient, broad spectrum antibiotic, the panel pneumococcus. We can step down easily. Syndromic panel is really useful here. Now, somebody with a syndromic panel detects Pseudomonas or Acinetobacter and resistant genes, no NDM, no KPC, no genes identified. That doesn't mean carbapenem resistance is not there, because carbapenem resistant Acinetobacter, Pseudomonas, the resistance is so complex, you can't identify, do genetic analysis alone. That is available in the PCR panel. So these PCR panels have got their limitation. We need black and white culture and MIC for culture. Culture is still the king. Culture is still the gold standard. Now, this multiplex PCR panel, they don't detect semi-quantitative or quantitative. They report it as a bin. A bin is a semi-quantitative category of nucleic acid detection by a molecular panel. It interprets range of copies, not the count. It's range of copies. This distinction is very important. The bin is not equivalent to a culture colony forming unit because the PCR detects nucleic acid. Culture detects live organism. But still, a high bin means high nucleic acid signal. Again, not necessarily high viable bacteria. It could be dead bacteria too. Now, how bin should be interpreted clinically? Always interpret together with the specimen type. Is it a BAL or endotracheal aspirate? The gram stain finding, the clinical syndrome, the radiology, the host immune status. A multiplex PCR result has no value unless there is an interpretation algorithm. Unless there is an interpretation algorithm. Unless there is a clinical treatment algorithm. Now, let us look at this scenario. The endotracheal aspirate, low bin Pseudomonas. It looks like a colonization signal. The key interpretation rule is the burden, the plausibility, and the specimen type give you the meaning. These bins are just signals. Clinical reasoning assigns significance. The clinical reasoning assigns significance. Now, do rapid diagnostic actually improve patient care? This is the Inhale WP3 trial design published last year. These are a UK multi-center trial comparing rapid syndromic PCR testing combined with a prescription algorithm. The trial is not just syndromic panel report on one hand and conventional culture on the other hand. No, a PCR report along with a prescribing algorithm. There is an algorithm the doctors need to follow after they get a result. So one hand, the PCR report and algorithm, other hand, conventional microbiology results. Adult population, randomized control trial. Now, the traditional workflow, culture result available in 72 hours. Rapid workflow, actionable result in 3 hours. You got a multiplex PCR result and there is interpretation algorithm. So, earlier microbiologic information is available. Its speed of diagnosis can change early management decision. So, the Inhale trial evaluates the clinical impact of diagnostics, not just laboratory accuracy. I'm stressing that word. We are not analyzing the laboratory accuracy alone. We are analyzing the clinical interpretation algorithm importance of that particular group. So, what was the primary endpoint was a stewardship endpoint. Active and proportionate antibiotics at 24 hours. So, what difference a multiplex panel and interpretation algorithm makes in 24 hours? Clinical endpoint, the clinical cure rate after day 14. That's a secondary endpoint. What was the result? More patients receiving active and appropriate antibiotics at 24 hours. No doubt about it. That means earlier appropriate therapy. Earlier narrowing when possible. Now secondary, the trial did not demonstrate non-inferiority for clinical cure at day 14. But that doesn't mean the patient's outcome was not impacted by the PCR and algorithm. The trial was not designed to be powered for proving non-inferiority because the 24-hour antibody stewardship is directly dependent on the PCR result. But a 2-week outcome is dependent on so many other variables. Patient's clinical status, immunocompromised status, and so many other variables. And the study was not powered for that particular secondary endpoint. There are so many other variables impacting the 2-week life outcome. Let us look at this scenario. A rapid result, antibiotic adjusted at 6 hours. Standard culture adjusted at 48 hours. Both patients recover. Outcome may be the same, but antibiotic exposure is different. A rapid diagnostics mainly improves stewardship. May not be mortality, we don't know. It may be improving mortality, but we don't have the data yet. Look at this slide. You know, those who are into perfumes know the oud perfume. You know where the oud come from? Oud is produced by a tree called agar wood tree. And the most famous oud is from the Assam in India. You know how the oud is produced? If the tree bark is damaged by any way, the fungus grows in these holes and attack the tree. You know which fungus? Aspergillus, muco, scedosporium, fusarium. Exactly the kind of fungus that kill our immunocompromised patients attack the tree. And the tree fights back by producing a resin called oud. That amazing, that divine oud, the smell of the oud, that oud is produced by the tree has a resilience to attack by fungus. The same fungus kills our immunocompromised patients. On one end, that creates the beauty and the fragrance of the nature. On the other end, the same fungus produces the destruction, the death in intensive care units and transplant units. The same microbes can produce amazing aroma. The same microbes can kill our patients. Look at the petrichor. Petrichor is the smell of the scent of the first rain when the rain falls on the earth. That smell is called petrichor. You know where it's coming from? It's from an oil from the soil called geosmin. That oil is produced by the soil bacteria and fungi. Again, the beauty and the fragrance of the microbes in the nature. On the other end, the same microbes kill our intensive care patients, and they produce the smell of putrefaction. Pseudomonas on one end, the sweety odor of Pseudomonas. On the other end, after death, the death of the smell of putrefaction by Pseudomonas. The biomarkers, we know PCP plays a significant role, not in starting antibiotic, it's useful in stopping antibiotic, it's stepping down antibiotic. Several trials have proven. Now there are host transcriptomies. There are several host transcriptomies that is being developed that can help us to differentiate between colonization, infection, bacteria, and virus and non-infectious inflammation, where several promising host transcriptomics are being developed. Now come the metagenomic NGS. Dr. Mahua thinks 24 hours a day. And Dr. Mahua wants us to do NGS for every patient, maybe in the future. Currently, what's the role of NGS in pneumonia? What is NGS? What is metagenomic NGS? Metagenomic next generation sequencing is an unbiased, broad range diagnostic test that detects nucleic acid from bacteria, virus, fungus, parasites, atypical organism, everything in a single assay. Everything. It's a pan-pathogen metagenomic NGS. This is a powerful tool. Why this is a powerful tool? The traditional test looks for specific pathogen. Metagenomic NGS looks for everything that is present. The nuclear, the DNA, RNA of microbes present in the sample. This is especially useful when routine tests are negative or inconclusive. This is not a routine pneumonia test. This is of high value if you treat immunocompromised patients. 90% of my practice is in a cancer center. And I know how so many patients, the bronchoalveolar lavage, culture negative. And we are expecting a lot of unusual organisms where routine culture or routine pneumonia multiplex panels will not give us an answer. So this NGS can play a significant role in immunocompromised patients. Severe pneumonia with negative cultures. Rare antibiotic exposure, we know the culture will be negative. Unusual or rare pathogen suspected, especially unexplained pneumonia syndrome, maybe a new pathogen, maybe a rare pathogen, especially in immunocompromised patients. Unexplained respiratory failure, NGS can play a role. But now, think about an ICU, any major ICU, especially with immunocompromised population or even immunocompetent population with severe pneumonia. You will see plenty of patients with BAL culture negative, sputum culture negative, ET culture negative, even BAL culture negative. And we may not know what to do with this. Culture negative, multiplex PCR negative. That's the role of metagenomic NGS. And any hospital, any major hospital ICUs or immunocompromised ward, anywhere in the world will have plenty of such pneumonia patients. Look at this patient, post-transplant patient with progressive pneumonia. Routine cultures are negative. Multiplex PCR negative. Metagenomic NGS detects pneumocystis. What's the interpretation? Previously undetected pathogen identified by multiplex PCR and culture. So what's the message? Metagenomic NGS is most valuable when conventional diagnostic fail. But we have plenty of patients where conventional diagnostics fail. What's the bottom line? Metagenomic NGS expands the detection capability, but interpretation must expand equally. Look at the multiplex PCR, the inhaled trial. It succeeded because of an interpretation algorithm. For a NGS is concerned, such an algorithm is being developed because it's a new technology. Multiplex PCR is an older technology with more evidence. And whenever new technology comes, it always takes time. There's always a lag period in generating high quality data. That doesn't mean we should keep the new technology away. No, there's always a gray area. That gray area need to be filled by more evidence, more clinical experience. Now, higher pathogen detection rate. Look at the conventional test, 20 to 40% pathogen detection test in pneumonia. metagenomic NGS that become 60 to 80% detection test. A significant broadening of the detection by metagenomic NGS. Some of the studies, 98% in some hospital-acquired pneumonia cohorts, you get an organism that's clinically relevant through metagenomic NGS. We discussed especially culture-negative pneumonia, antibiotic pre-treated patients, immunocompromised patients. Which are these bacteria? Look at the nocardia. Nocardia is a slow growing. It takes days to get a culture report from microbiology. And I'm not aware of any multiplex PCR having nocardia, but metagenomic NGS, you can get it fast. Rhodococcus, immunocompromised patient. Atypical mycobacteria is an important pathogen for pneumonia in immunocompromised patients. New viruses, like COVID, a new virus, no multiplex PCR will detect because multiplex PCR needs primers for each organism. So whatever in the menu, you can eat. Whatever in the menu, you can use. Anything out of the menu, you won't be able to get from the buffet. But metagenomic NGS, there's no defined buffet. Anything in the world, you can order. That's the difference between multiplex PCR and metagenomic NGS. Now, fungi, Pneumocystis jirovecii, multiplex PCRs will not detect unless you do a separate PCR, pneumocystis PCR. But metagenomic NGS can detect pneumocystis in the NGS panel. Aspergillus, rare mold like Fusarium, Scedosporium, parasite like Toxoplasma, all these can be detected by metagenomic NGS. All these are common in immunocompromised patient population. So, a metagenomic NGS can play a very big role in treating culture-negative severe pneumonia, unexplained pneumonia, and pneumonia in immunocompromised patient population. And any hospital anywhere in the world will have plenty of immunocompromised patients. And again, pneumonia is a commonest syndrome in immunocompromised patient population. And culture negativity, unusual culture negativity is a common problem that we come across while treating this immunocompromised patient population. And metagenomic NGS is also useful for identifying polymicrobial infection, a bacterial infection and a virus infection, a bacterial infection and fungal infection. This combination of bacterial and fungal infection are not identified in any commonly available multiplex PCR panels. For example, in my oncology cancer patients, I will have a Klebsiella pneumonia, but underlying there will be a mucor brewing up, or Aspergillus, or a Fusarium pneumonia underlying. I've seen plenty of such patients with co-infection. That's the advantage of the metagenomic PCR, metagenomic NGS. Mixed anaerobic infection. You know, a lot of anaerobes can't be grown, but metagenomic NGS can identify these mixed anaerobic infections from samples. And there is studies that proven that metagenomic NGS can significantly help in antimicrobial stewardship, in escalation, de-escalation, targeted therapy. Yes, it may not be as fast as a multiplex PCR. Multiplex PCR, you get the result in few hours, and metagenomic NGS needs 24 to 72 hours. Metagenomic NGS is faster than culture, but not as fast as multiplex PCR. But the breadth of the organism identifying and the sensitivity or the pickup rate is significantly more than multiplex PCR. So clinicians can stop unnecessary broad spectrum antibiotic, initiate targeted antifungal therapy. This fungal, none of the multiplex PCR to my knowledge have got fungal detection. But metagenomic NGS will help you in that. Atypical organisms, for example, PCP pneumonia, many of the viral pneumonia, detecting rare bacterial pathogens. I gave the example of Rhodococcus. It's not there in any of the panels, and Rhodococcus is very, very difficult to grow. So we discussed this. Metagenomic NGS has a broad impact in severe pneumonia, ICU patients, immunocompromised patients, like cancer, transplant, prolonged steroids, neutropenia. They're all at risk of unusual fungi or common fungi. And some of the fungi won't grow, you know that. Opportunistic pathogens, mixed infections. Now, what is the limitation of metagenomic NGS? The biggest problem is the difficulty distinguishing colonization versus infection. Now, this is a problem not just for metagenomic NGS. This is a problem for multiplex PCR too. But, trials like inhaled study that I described had an interpretation of treatment algorithm. Using this algorithm, this algorithm helps differentiating colonization and infection to a great extent. We don't have such an algorithm for metagenomic NGOs. I'm sure more and more studies will help us develop an algorithm, and that will help us to solve this challenge to a great extent. Currently, yes, distinguishing colonization infection, of course, this is a clinical interpretation. So we need to use our clinical judgment, not just judgment. I believe hospitals should have written algorithm on how to use metagenomic NGS. Now we need to differentiating between colonizers and pathogens again needs clinical interpretation. And there are no standardized threshold, no predominance threshold for this. Unlike a quantitative culture, MNGS reports, they give you relative abundance. But the problem is there's no universally accepted cutoff to define what's a true pathogen, what's a colonizer, and this complicates interpretation. Of course, we need to use the clinical judgment for interpretation of MNGS results. Next problem, expensive. But many of the multiplex PCRs are more expensive than NGS panels available in the country. Technologically demanding, but of course, this is not that difficult for a molecular laboratory. Most testing is currently limited to specialized reference laboratories. Of course, either we can have our own specialized molecular lab, or the test who the senders would do have expertise in doing this test. Turnaround time, 24 to 72 hours, faster than culture, but not as fast as PCR panels. Then, this is my final opinion. A diagnostic strategy of metagenomic NGS should not replace conventional diagnostic. No, not as of today. Maybe after a few years, not today, but rather complement them. We need a hybrid diagnostic model that includes gram stain, culture, PCR, antigen, and metagenomic NGS in selected cases. When I talked about selected cases, any hospital in the country, anywhere in the world have plenty of these selected cases. So this combination maximizes diagnostic yield while minimizing misinterpretation. If you do all these things, to a great extent, we can overcome the challenge of differentiating colonization and pathogens. Use the gram stain, culture, PCR panels, and the clinical interpretation. Future NGS scientists should work to develop standardized bioinformatics pipeline is still a challenge. The pathogen abundance threshold, cutoff point, what is colonization, what is pathogen, interpretation guideline, treatment algorithms, interpretation algorithms. And in future, the metagenomic NGS results can be integrated with host transcription biomarkers, because these biomarkers can help us to differentiate colonization, infection to a great extent, differentiating bacterial and viral. So if we combine metagenomic results with host transcriptomics biomarkers, with gram stain, with culture, with clinical interpretation, that will make a great difference in the clinical utility of metagenomic NGS. So what is the message? MNGS reports 12 organisms in a patient, each with a low read count. What's the interpretation? Likely background contamination or colonization. So dominant signal matters more than the number of organisms. The clinical rule is the dominance of that pathogen and the plausibility of that pathogen to be a pathogen. That's a pathogen likelihood. So MNGS results must be interpreted clinically, not just reported blindly. Should be interpreted clinically. Now there are a lot of other technologies coming up. The breath. I love volatile organic compound because of my interest in perfume and skin microbiome interaction between perfume and the perfume volatile organic compound and the skin VOCs. So, but it's not just a passion, plenty of studies are coming up for using volatile organic compound in the breath or in the sweat for diagnosing not just pneumonia, cancers, infections. In fact, there is a study where we can measure the volatile organic compound of the skin, and the diagnostic accuracy of malaria is more than the malaria PCR. But currently, it's a challenge in diagnosis. A lot of studies in cancer, a lot of studies in diabetes, metabolic disorders. So pneumonia, in future, you may have very, very bedside, the e-nose, we can call it as electronic noses for detecting volatile organic compound and diagnosing pneumonia and many other syndromes. And I would call breath is a perfume and disease changes its composition. Breath is a perfume and disease changes its composition. If you're able to measure this change using, currently you need a machine called GCMS machine, costs more than 1 crore. Not possible in an emergency unit or any hospital. What if you have very, very low cost point of care eNose chips which can detect the volatile organic compounds? You can diagnose diseases fast. So, after all the story, what we understood, there are so many tests. Gram stain, culture, antigens, triple PCRs, viral panels, pneumonia panels, metagenomic NGS, transcriptomics, VOCs. There's no dearth of tests. What we need is an interpretation algorithm. So, this is the algorithm that I developed. A simple algorithm. Anybody can develop this algorithm, not rocket science. Step 1, choose the specimen. Moderate, severe community-acquired pneumonia. Sputum, if good quality. ICU patients, ETA and or BAL. Immunocompromised patients, go for early BAL. Go for early bronchoscopy and BAL in immunocompromised patients. Step 2, immediate early test. Gram stain, targeted viral PCRs like flu, COVID, RSV guides the initial therapy decision. Step 3, early microbiology, semi-quantitative culture. And syndromic pneumonia PCR panel, if you believe the result will change therapy within few hours. Step 4, you reassess the patient after 2 days, 48 hours. Review the culture results, early clinical response, the biomarker like a PCT trend, narrow down or stop antibiotics. Step 5, escalate diagnostic if unclear. You do BAL, you do metagenomic NGS, you can do transcriptomic, pathogen, targeted pathogen testing. Step 6, future roles like a breath VOC analysis and AI-assisted diagnostic. This is the role of, this is how we are going to utilize the conventional test and the new test. Look at this example. A ventilated patient with suspected VAP, endotracheal aspirate, gram stain, gram negative road, panel, high burden Klebsiella, culture confirmed Klebsiella, PCT falls by day 3. So the diagnosis confirmed early by gram stain itself and therapy safely shortened. Integrated diagnostics optimize antimicrobial stewardship. Diagnostic should guide therapy dynamically, again and again, not just once. Pneumonia diagnosis is not a single test. It's a staged decision process. So the specimen is the first test. Culture is the anchor of pneumonia diagnosis. Rapid test improve timing, not your judgment. Biomarkers guide stopping, not starting. Advanced tool like metagenomic NGS or a multiplex PCR should be selective. Diagnostics must be integrated into the stewardship. And the best pneumonia diagnostic test is the one that changes the management safely. Again, an alcohol-based perfume is a song, like a song. Have you used oil-based perfume, conventionally called as attar? Recently, I published a paper. I coined a term called jwale instead of attar because attar is commercially broken, heterogeneous, cheap synthetics, high quality. So I coined the word jwale. Why the natural ones are more important? For a rose alone, you need 800 volatile organic compound in the nature. Jasmine alone, 500 volatile organic compound. So if you produce a complex attar of dozens of components, we are talking about thousands of VOCs. And natural jwale can contain thousands of VOCs. So this is the paper I published on the case for jwale. Now my message is, just like the fragrance, just like the microbes producing an amazing fragrance in the nature, and the same microbes kill our patients. It's up to us to look at a perspective on the life. You can have a positive attitude to life, like the good microbes, or we can look at the negative things like a bad microbes too. 99.99% of the microbes in the world are good. They enjoy life. They produce fragrance. And that's a message of life from microbes to the humble humans. Thank you.
Thank you so much, sir. And again, It was a very engaging presentation and a very scientifically justified deliberation. So, as actually expected, sir, it was fantastic. I hope my slides are visible.
Yes,
Are they?
we can.
Right. Um, this is a very small snapshot. In the last 2 years, with our flagship product, Infection NGS, which is pan-bacterial, pan-fungal, 13 respiratory viruses, 2 neuropathic virus, HSV1 and 2, and 11 antibiotic resistant genes, which are the antibacterial ones. So this comprehensive detection performed on bowel fluids, ET aspirates. Sputum is not a part of this analysis. So we restricted to just ET aspirates and bowel fluids. The reason being, as sir has rightly mentioned, the quality of the specimen really matters. And since for sputum, we as a performing center or centers where we perform, we do not always have the scope of a Q score. So naturally, being unable to differentiate between a sputum and a saliva, we have removed it. Well, it's an off-label use, but we have not included it in this interpretation or in the insights that we have. What I want to give you a glimpse of is when we are doing this kind of a targeted next generation sequencing direct on clinical samples, in the reports, this is what we saw. For some of them, we could go back to the clinical informations provided, and then we performed the next set of analysis basis the information available. Broadly, whether the patient was in SIRS, where we took the criteria we usually used to use when the sepsis 1 criteria was in place. The other were radiological evidences, if mentioned. The third was whether the clinician providing the sample had suspected as a provisional diagnosis a respiratory tract infection. So, and then of course, whether there were any inflammatory biomarkers which were high in the patient. So these were broadly the categories where we assessed whether the patient had a pre-test likelihood of pneumonia or not. Now, in microbiology, we usually would prefer to classify, like there are many methods of classifying organisms, some of them being a true pathogen versus a commensal versus a contaminant. Currently, what I find the most useful is if we can classify into obligate and opportunist. And why I prefer this is because, as Dr. Ghafur mentioned, that in the immunocompromised host, there are a lot of these commensals or the environmental which can end up being opportunists. So we cannot actually rule out anything. It becomes very difficult in such cases to rule them out. They are opportunists, and we have to take that with a pinch of salt. In the obligate category, it is never a worry. We see these organisms, we know that given the clinical pretest likelihood, we know that the patient is suffering. What is very interesting was when we get something like a Trophirima vipili, when we go back, while this may seem anecdotal, we have so far seen it in 2 patient cases, this would not grow in cultures. And when we see something like this, we go back and check that, yes, it has a mention. It is very well evidenced that this can cause, while not a very frequent cause of pneumonia, but it can cause lower respiratory tract infection as one of its presenting symptoms. Now, why I insist here that, as Sir said, that I want every physician to perform NGS for every case and not be selective. My reason being, while we would want to be, the clinician might want to use NGS when a routine culture is failing. My experience of 18 years in a clinical microbiology lab and the way I have seen the cultures and the PCRs evolve and being performed and what it is capable of delivering, what I feel is even one patient should not have a delayed diagnosis. So if I have the opportunity to add on targeted NGS along with the culture of cultures, which definitely, sir, is very right in saying that it provides the opportunity to perform a phenotypic susceptibility, I still cannot remove this window of early detection from any patient. So this was for obligates. When I talk about opportunistic commensals, and I'll show you a few things, I came across very interesting studies today when I was preparing. These are the commensals. These are mostly the oropharyngeal commensals, which we have seen in most of these lower respiratory tract samples. So I'll come to the interpretation part. Again, abound. In most of the respiratory reports, we have seen the presence. There were the aerobes, there were the anaerobes, there were the capnophils, all of them, and different species of different genus. When it comes to the environmental, as sir mentioned, yes, we have seen the molds, both the hyaline molds, the dimetitious molds, the very rare ones. So a lot of genus and species that we observed. And in case of bacteria, not only the routine non-fermenters we talk about, but the list has grown beyond what we could have ever imagined, what is lurking in our hospitals. So when we saw this and when we had discussions with clinicians, just the way sir has made a fantastic protocol of approach, this is my bit into the understanding. When I see an obligate pathogen, and if I have good radiological and clinical supportive evidence, probably not very essential in case of obligates, whether it is a single or a multiple detection, we just need to figure out that this might be a monomicrobial or a polymicrobial infection. Like we see the case of, we have seen a virus with the presence of a mycoplasma pneumoniae. So yes, it is a polymicrobial we are seeing. When it came to an opportunistic commensal being detected, now either it could be a single commensal, it could be it could be multiple commensals being detected. Now, suppose this single commensal is a Streptococcus pneumoniae. Now, we know that we harbor it in our upper respiratory tract. It is there as a commensal in a lot of healthy cohorts, while it may gain access to the lower respiratory tract and can result in a pneumonia. In such an organism, this may not be very difficult to discern, but in case of a non-cap organism, where we are seeing a lot of oropharyngeal, it could be a polymicrobial where we need to rule out aspiration pneumonia. And these are some of the things, sir. I would want your insights. I would want you to deliberate on these. Maybe we can sit, discuss, and then bring it back in the next webinar. About if faced with these situations, how can we approach it clinically, how it fits into the algorithm that you have made, and can we give some guidance then to the use of this? So when we say commensals or contaminants or colonizers, it is now being evidenced that a lot of them have been under recognized causes of LRTIs. It is even the periodontal diseases are being very closely linked to the lung health, and it is a very common cause of hospital-acquired pneumonia, given the fact that, especially in the intubated patients, the likelihood of aspirations or the secretions reaching to the lower lungs. So yes, I think Dr. Pramod, that partly answers your query of what an NGS report might look like. When you are talking about the resistant genes, sir, our test has targeted 11 genes, which are important for antibiotic decision making, where we need a genotype. Let's say whether it's a carbapenemase producing and which is the gene, or whether it is MRSA or MEK presence, the MCR1 for colistin. So otherwise, if we want the complete resistance profiling, we would need a whole genome sequencing, which is time consuming and probably lacks utility in a routine clinical diagnostics where time is the essence. So that has more research applications. So I think, sir, we
Wonderful.
are at the end of this session, and there are no further queries. So thank you so much, sir. Very insightful. We have a lot of learning, and I think we have some cues of how to improvise on the platform as well. So
Thank you, Mahua, and thank you, the audience.